Or well, welcome everybody. I am Matthew Budoff, a professor of medicine at Harbor UCLA Medical Center at Torrance, California. And I'm going to be talking to you today about informing coronary artery disease prevention by using plaque quantification. This is my conflict of interest. So first, what have we been able to do with cardiac CT? What's new? And then we're going to go through a little bit of how we can inform our decision making. And I think we're all familiar with the Prevent online calculator, looking at a risk estimator, but it really is, one, it's population based, even though it might be a little better than the previous pooled risk equation. It's still just a population based assessment, and it still misses some of the information that may end up being vital. So I think almost everybody would agree that directly measuring plaque, getting a independent person's risk can really personalize our approach to that person. And certainly there's a lot of opportunities in cardiac CT that we'll talk about today to assess rather than to estimate what disease burden they may have. So first and foremost, a normal CT, I think this is something that just needs to continue to be reiterated. If you have a CT angiography that shows no plaque, we really do have a near perfect warranty period of about 8 years. You can see this is work from Fink. And as we find more plaque in the coronaries, here defined as CAD rads for percent stenosis, you can see worsening outcomes over long-term follow-up. We're also all familiar with this simple concept that a picture is worth 1,000 words, that you show people plaque in their coronaries and they will behave better. The seeing is believing is truly been something that we've all experienced, both with coronary calcium and now even more so with cardiac CT angiography. This is 5-year data showing increased utilization of antiplatelet therapies and increased utilization of statins over a long period of time, which I think is very important when you start talking about compliance, that we get long-term compliance boosts out of this. So understanding that we can see the plaque and hopefully enable our patients to be better patients, what can we do now with plaque quantification and what new tools are available? And these are 3 tools that are available from HeartFlow. We see the roadmap analysis on the left, which gives you a quick view of the entire coronary tree and where the stenoses are. Plaque analysis, we're going to talk about today, about the ability of looking at plaque and quantifying plaque and using that as a metric for treatment. And then, of course, the information we also garner from FFR-CT and how we can use that information to plan our patients' future. I'll start with the FFR-CT briefly, just to take you through this. This is an FFR-CT analysis. This was done and just recently published by Madsen, looking at long-term outcomes with patients with FFR-CT. And these are the event rates for cardiovascular death or MI, so nothing to do with revascularization, which obviously goes up as we identify these stenoses. But if we just look at the hard cardiovascular events, you can see that those patients with an abnormal FFR-CT were almost 9 times more likely to suffer a cardiovascular event as compared to those patients who had a normal FFR-CT. And this is powerful information to assess patient-specific risk of major adverse cardiovascular events. But we can go beyond that now. We can go beyond FFR-CT and independently quantify plaque, not only total plaque volume, but by type: calcified plaque, non-calcified plaque, low attenuation plaque, and really get at the patient's true risk by understanding their value. And this tool has been highly validated. You can see on the right the correlation between AI the plaque volumes and intravascular ultrasound, and there was a 95% agreement with intravascular ultrasound in assessing total plaque volume. So it really gives us an excellent accuracy in both quantification and characterization of the plaque. I think the most important thing that we're now recognizing is the step up that we get beyond coronary calcium. Here you can see calcified plaque in orange in different age groups, women on the left, men on the right. But you can see that a good percentage of the plaque is non-calcified plaque. And more importantly, the relationship between calcified plaque and non-calcified plaque changes in both based on sex and based on age. Obviously, if we further break this down, we're going to see different associations in patients with diabetes, patients who are smoking. So I think understanding that we get more information and more pertinent information about the total plaque burden with CT angiography as compared to a coronary calcium score is going to lead us to better treatment options. Another advantage is we can use this tool to follow patients over time with quantitative plaque, where of course coronary calcium is not the best surrogate to follow over time given its unusual association with statins and increasing calcification with statin therapy. So this is a nice a publication that just recently came out looking at plaque staging and cardiovascular outcomes. So now in red, we have no plaque. This is percent atheroma volume of stage 0. We have a population of patients who had perfect long-term outcomes, both from MACE on the left and from MI, stroke, and death on the right. You can see increasing events or worse event-free survival as you go up in the stages, and it's very linear and stepwise. As you go to green, percent atheroma volume stage 1, we see increased events. As we go to dark blue, stage 2, we see more events. And as we go to stage 3, we see even more events. And I'll take you through the stages in a little bit as far as exactly how much plaque that represents, but more plaque, worsening cardiovascular outcomes. This was a nice study. This was done by Sarah Reinhardt, looking at the DECODE study. So they looked at a management plan based on CT angiography. We used 3 practicing cardiologists with level 3 reading certification, and they looked at 100 patients and they said, what would you do based on what you see as far as plaque on the CT angiogram? Again, staging them with no plaque, stage 0, mild plaque, and moderate and severe plaque, stages 1, 2, and 3. And then they added in the heart flow plaque. And then they said, okay, now based on the additional information about plaque volumes, this is what happened. And you can see 58 out of 94 patients, so over 60% of patients actually were underestimated based on the CT angio without the heart flow plaque. When we added in the plaque, they were actually stage 3 and actually lend themselves to more aggressive therapy. Nearly half of patients with a calcium score of 0 were reclassified, most of them to stage 1, but still we found plaque and therefore were able to implement different therapies. And you can see what at least one proposed algorithm of care would be. Stage 1, we put on low-dose statin. Stage 2, high-intensity statin with PCSK9. And then stage 3, more severe plaque, add in additional medications. And we'll talk more about some potential algorithms of care as we identify patients with more severe atherosclerosis. So how can we inform risk prediction and get more confidence that what we're seeing, both from a hemodynamic consequences and from plaque characterization consequences, are going to help identify high-risk patients, thus warranting more aggressive medical therapy? So this is a nice study looking at acute coronary syndrome events, looking at both plaque and physiology. And you can see here APCs, or adverse plaque characteristics, and AHCs, or adverse hemodynamic characteristics. And if you have neither, the event rate in this study was quite low. If you have either a plaque or adverse plaque characteristics or abnormal hemodynamics like FFR-CT abnormalities, your risk goes up 2.5-fold. And as you go towards both adverse plaque characteristics and adverse hemodynamic characteristics, your risk goes up about 7-fold. Now, more than half the patients from these culprit lesions ended up with adverse cardiovascular events. On the right, you can see the cumulative risk for culprit lesions, and again, neither in green, but either in blue, and then the event rates so high in patients with both abnormalities. This is the advanced decay plaque results, and we can see if we assess residual risk, looking at this precision, if we look early at these advanced decay plaque results, but you can see in yellow, if you have an abnormal FFR-CT, you have early events. If you have abnormal plaque, so green is plaque without abnormal FFR-CT, you end up with late events, and you can really get information from both. We can act early on the abnormal FFR-CT and hopefully revascularize these patients. I'll show you a study looking at complete versus incomplete revascularization. And then if they have plaque, we can address that for long-term consequences and progression of disease that would lead to further cardiovascular events. So here you can see in green, FFR-CT negative, plaque positive, late events because the FFR-CT was normal. You can see in yellow, FFR-CT abnormalities without a lot of plaque characteristics, early events from the abnormal FFR-CT, and of course, if they have both, a progressive increase in cardiovascular events. So this is a nice study looking at completeness of revascularization, again presented at TCT, and you can see incomplete revascularization with based on FFR-CT in red, and the event rates if we didn't fully revascularize this population. You can compare that to the patients who had abnormal FFR-CT but underwent complete revascularization, and that continuous separation, that blue area, as events continue to accrue over 7 years of follow-up. And then you can see the relatively low event rates overall from a normal FFR-CT, but similar to what I just showed you, the events start to accrue after a few years because they're FFR-CT negative, but they might have atherosclerosis underlying that would lead to later events as that blue line starts to creep up. So when we think about this and break it down, if we talk about the population of patients with incomplete revascularization, the events are driven at the top by FFR-CT. This is a population of patients who are going to be 2.2-fold more likely to have a death or a spontaneous MI because they have incomplete revascularization with an abnormal FFR-CT. If we look at those patients who underwent complete revascularization, looking at the top, what's the difference in FFR-CT for high versus low? Not statistically different, but at the bottom, does plaque burden make a difference? And the answer was yes. And those patients with high plaque burden above the 50th percentile had 5 times more events as compared to those patients who got complete revascularization but had a low plaque burden. So plaque burden dominates once you fix the FFR-CT abnormalities. And in those patients with a normal FFR-CT, of course, no difference in the top because there's no differences in FFR-CT. The event rates were similar, but total plaque still predicted events with a hazard ratio of 2.09. So we can see curve separation based on plaque once we fix the FFR-CT. If we don't address the FFR-CT, then the FFR-CT measurements drive cardiovascular events. So let me show you two patients, both 54 years old, actually a woman on the left and a male on the right, but both of them had symptoms. They both had negative functional tests, and they both underwent CT with FFR, and both had what we would call a gray zone between 0.75 and 0.79 or 0.80 measurements on FFR CT. So both of them had mild abnormalities of perfusion at the distal tip of the LAD. If we look at the plaque burden of the woman on the left, who had a gray zone FFR CT, you can see she had a very large plaque burden with diffuse atherosclerosis. That's the LAD rotated at 0 degrees, 60 degrees, and 120 degrees. And you can see total plaque volume of 634 millimeters cubed. So she had a high plaque volume and a gray zone FFR CT. On the right, the male had also a gray zone FFR CT, but had very little plaque, had a total plaque volume of only 26. So very little plaque with no low attenuation plaque in his coronary tree. And if we look at where the woman was, she's way off the scale for her age and sex, and you can see a very high percentile of plaque. The man, on the other hand, a very low percentile of plaque, and different differences that we would then treat based on the total plaque volume. The woman would presumably get much more therapy given the high plaque volume, also with that borderline FFR CT, as compared to the man who had a similar FFR result, but a much different plaque result. This is an algorithm of care that's being utilized, being in the DECIDE registry. This is a large registry. They're enrolling 20,000 patients, but you can just see an algorithm of care proposed to identify those patients who have mild plaque, total plaque volume of 1 to 100, recommended treatment with statin and aspirin, moderate plaque, intensify therapy, add additional agents as needed to get the LDL lower, severe plaque, lower LDL goals, more therapy, adding in additional treatments as needed, thinking about their diabetes and additional treatments and CRP. And then finally, extensive plaque, total plaque volume above 750. And you can see lower LDL goals and now consideration of even more additional therapy. So just basing intensity of risk from total plaque volume to intensity of therapy on the right. So when we think about how we can inform coronary disease prevention, we can accurately quantify and characterize plaque with a CT angiography, just acquired the way you normally would, but now with additional information for plaque characterization and FFR CT. We can inform and manage residual risk by addressing the full burden of coronary plaque, and we can now guide treatment strategies to target disease. And I think this is going to be the future of prevention, is personalized medicine, but taking it beyond a calcium score to flow and outcomes. One last thing as we finish up, this is the AI plaque analysis, Medicare coverage update, and we are now fortunate. You can see the different providers for coverage, and most of the country now for Medicare, based on these local coverage determinations, are covered for AI plaque, considered reasonable and medically necessary when the patient is eligible for a CTA and the patient presents with either acute or stable chest pain and is in an intermediate risk for coronary disease or is evidence of CAD-RADS 1, 2, or 3 disease. So that's up to 70% stenosis, 1 to 70% stenosis, and they have a negative or inconclusive for acute coronary syndrome. Obviously, if they have an ACS, we're not going to be putting them into this algorithm of care. We're going to be treating them more aggressively. So this is great news, brand new data for the West, where we now have a positive local coverage determination. So I'll stop at this point. Thank you all for your attention, and look forward to a very productive and engaging meeting for the rest of the day. Thank you again for joining me.